I'm going to introduce our current clinical track session. You'll see our lovely panelists here. Moving from my left, your right, over to Donnell, we have Dr. Stephanie Forte, who is a hematologist at the CHUM stands for?
CHUM is the Montreal University Health Hospital. Yeah,
Thank you very much. Montreal University Health. Shane Justine. She leads a team at the Red Blood Cell Disorders Center at the University of Montreal Hospital and teaches at the University of Montreal. Her research work focuses on understanding why some people with sickle cell disease develop problems with the brain and nervous systems so that the better care and prevention can be offered. Next, we have Dr. Andrea Servi, longtime contributor and supporter of the SCAGO. She's also an adult hematologist practicing at the Windsor Regional Hospital, where she serves as the division head of the thrombosis department and director of the adult hemoglobinopathy clinic. She obtained her master's in science in biomedical and molecular sciences at Queen's, followed by her MD at U of O, and she's currently focusing on, she also has a practice in mixed malignant and non-malignant hematology based entirely at the Windsor Regional Cancer Program. And last but certainly not least, my dear colleague, Dr. Donnell Ivey. He serves as both Education Program Manager for SCAGO and is also the Chief Medical Officer for the Sickle Cell Disease Association of America, the SCDAA. Dr. Ivey's worked with the U.S. federal government for over a decade on sickle cell initiatives, including the Sickle Cell Disease Treatment Demonstration Program and the National Health, Lung, and Brain Institute's Sickle Cell Guidelines of 2014. He has a number of degrees from a number of prestigious universities, which you can all read more about on page 38. And without further ado, I introduce the acute chest syndrome and pulmonary hypertension, how to spot it, and the best way to treat it, a concurrent session. Over to you.
Okay, thank you so much, Delaney, and thank you to the session organizers for asking me to talk on this. So here are my disclosures. I'm going to be honest with this group. My true disclosure is that my baby girl has been up since 4:30 this morning. So if I break out into nursery rhymes, I should I should end halfway through. So so bear with me there. So basically, for the next 15 minutes, I do want to provide a brief overview of some of the risk factors, clinical manifestations, and tenets of treatment of both the acute chest syndrome and pulmonary hypertension. So sickle cell disease, as we know, is a chronic inherited red blood cell disorder that can quite literally impact on every organ system of the body. But for the purposes of this talk, we're going to be reviewing both acute and chronic manifestations of sickle cell disease as it relates to the cardiopulmonary system. And I did want to use a case presentation to illustrate both of these topics. So this is a case of a young gentleman, 22 years old, Mr. AM, who has hemoglobin SS disease and has had multiple hospitalizations for recurrent acute vaso-occlusive episodes, along with priapism. He has been prescribed Hydrea, but has had some issues with adherence to the medication. He's originally from Nigeria. He's been here for about 5 years and is studying political sciences at the local university. And so he presents to the emergency room with a 2-day history of fever, shortness of breath, cough, and bone pain. And as you can see from his vital signs, a few concerning features here. So he's certainly febrile with a temperature of 39.8 degrees. Respiratory rate is elevated at 40. Blood pressure is on the low side. He's quite tachycardic with a heart rate of 140 beats per minute, and he's requiring a 30% face mask to maintain his oxygen saturations greater than 95%. And so an urgent chest x-ray is done in the emergency room, and what we can see is that there's a new infiltrate in the right lower lobe of the chest. And when we pair that together with fever and respiratory symptoms, that does lend us a diagnosis of the acute chest syndrome. So the acute chest syndrome is an acute presentation that's quite unique to sickle cell disease. It is responsible for at least 50%, if not more, of hospitalizations among people with sickle cell disease, and it has a very heterogeneous course whereby in some individuals it may present as a mild infectious illness, but in others it can progress quite rapidly to acute respiratory distress and multi-organ dysfunction. There are many different causes of the acute chest syndrome, but in each of these instances, what's happening is that there's an acute insult that's decreasing the oxygen tension within the alveoli, and that's leading to differences in blood flow within that regions of the lung, causing sickling, vasoconstriction, reduced blood flow, and we're going down this feed-forward cycle there where it's further perpetuating this process. Most of the time, we think that infection is often responsible for the acute chest syndrome, but there are a number of other causes as well. So you can have fat emboli that can sometimes occur when there's a vaso-occlusive pain episode whereby you've actually infarcted the marrow and fat particles can then enter the bloodstream and embolize off into the lung field. We can see it in instances of pulmonary infarct, which can affect the microvasculature within the lung. We can also see that there's increased incidence of pulmonary emboli affecting the macrovascular as well. Hypoventilation, atelectasis, asthma, some or all of these issues can be present in the same person. There are a number of defined risk factors for the acute chest syndrome, and so probably one of the largest prospective cohort studies of individuals with sickle cell disease was the cooperative study of sickle cell disease published in 1997. This looked at a range of individuals that spanned the lifespan from infancy to actually individuals in their 60s, and it followed people for a median of about 5.5 years. And what this study found was that 50% of people with sickle cell disease may experience the acute chest syndrome within their lifetime, and that this tended to occur most often among individuals with hemoglobin SS genotype relative to other genotypes. Other risk factors include a reduction or a relatively lower hemoglobin F level, having an acute pain episode, again for reasons like bone marrow necrosis and fat emboli, asthma, postoperative setting where we see increased instances of hypoventilation or atelectasis of the lung fields, winter months owing to the impact of the colder temperature on vaso-occlusive pain along with increased risk of respiratory infections, bone infarct, smoking, hypoxia, and actually having a previous episode or history of acute chest syndrome can increase the risk of further acute chest syndromes. The clinical presentation is variable, but in general, what's been reported is that adults tend to have a more severe clinical course. And so when you look at differences among children and adults, essentially, while the relative frequency of these symptoms can vary, most often you're seeing fever, cough, chest pain, shortness of breath, bone pains, and sometimes even hemoptysis, which is coughing up blood. The tenets of management are multifold, and although we talk about them individually, they really all need to work together to complement one another. And so supportive care is key. Maintaining oxygen saturations of at least 95% is what's recommended by the majority of guideline societies, along with use of fluids, although we do want to be mindful that we're not overutilizing fluids in these settings, because if we increase risk of pulmonary edema, that can further perpetuate the acute chest syndrome, along with other entities like incentive spirometry as well. Broad and aggressive pain management is also one of the key factors of management here, along with broad-spectrum antibiotics, again, recognizing that in many instances, infection is often underlying the acute chest syndrome. Transfusion therapy is a cornerstone of therapy here, and that can be in the form of a simple red blood cell transfusion or sometimes exchange red cell transfusion, whereby essentially a unit of patient blood is removed and an allogeneic unit of blood is given to the patient. Both of these types of transfusion therapy serve to increase the oxygenation of the blood. In red cell exchange transfusion, that's also serving to reduce the amount of sickle hemoglobin, again, to try and essentially one of the ways is to abrogate that sickling process and that vaso-occlusion. And so when you would consider one over the other really depends on the clinical status of the individual. And so if you have a patient who is requiring higher levels of care, ventilatory support, or they're not responding to a simple red cell transfusion, that's going to be an instance where you're considering an exchange transfusion. And you also want to look at the baseline hemoglobin of the individual, because in instances of transfusion, you don't want to exceed a hemoglobin of 110 grams per liter, because that can increase hyperviscosity and further impair blood flow and contribute to the sickling process. So if you have an individual who has a higher baseline hemoglobin, then that might be an instance where you're considering them for red cell exchange. And advanced respiratory support for those individuals who need it would also be factored into the management here. There was a relatively recent study published a couple of months ago, actually, looking at the role of therapeutic anticoagulation with low molecular weight heparin among adults with sickle cell disease admitted to hospital with acute chest syndrome and who were considered to be low bleeding risk. And this is just a quick slide sort of outlining the study, but what this study found was that those individuals who were provided therapeutic doses of tinzaparin, which is a type of low molecular weight heparin, actually had faster time to resolution of acute chest syndrome and lower overall opioid use compared to those who were given preventative doses of low molecular weight heparin, which typically is what we would do for an individual admitted in any sort of an acute issue with sickle cell disease. So potentially over time, as we better understand these results, this might factor into the routine management as well in a patient who is otherwise considered to be low bleed risk. Prevention is also key, and so we really want to be ensuring that individuals are up to date in terms of their vaccinations and immunizations, again, recognizing increased risk of infection and the ability of infection to incite the acute chest syndrome. When we have patients who are admitted to the hospital setting, incentive spirometry has been found to significantly impact on the incidence of acute chest syndrome. And so taking those deep breaths in, as annoying as it can be, but really sort of pushing that for individuals can reduce the incidence of this terrible complication. Hydroxyurea, through a number of different mechanisms, has been found to impact on reduced frequency and severity of acute chest syndrome. And in certain instances, this is actually a consideration for cellular therapy, like allogeneic stem cell transplant or gene therapy, as was talked about earlier. And so back to Mr. AM, he did ultimately warrant a session of red cell exchange transfusion. He was admitted to hospital for 2 weeks. A portion of that occurred within the ICU, and he was subsequently discharged home. But now he's presenting 5 years later to his family physician's office, and he's indicating that he's been experiencing increased dyspnea with exertion, along with some leg edema. And so his family physician orders an echocardiogram, and I won't go through all of the details, but the takeaway points from the echocardiogram is that there are findings that are suggestive of pulmonary hypertension. So pulmonary hypertension is technically defined as a mean arterial pressure of 25 millimeters of mercury or greater. So essentially what we're seeing is that there's an increase in the blood pressure in the vessels that are subserving the lung fields. Okay, and hopefully through this graphic you can sort of appreciate how when that happens over time, you do get changes and remodeling of the right side of the heart, and that's oftentimes what gives way to some of the clinical manifestations of pulmonary hypertension. We can see the development of pulmonary hypertension for a variety of different mechanisms, and sometimes that can be pre-capillary, so prior to the vessels entering the lung fields, and post-capillary, which is after the vessels have exited the lung fields. And in sickle cell disease, you can have many different etiologies of pulmonary hypertension onset. Essentially, we can appreciate that there's increased risks of thrombosis within those vessels because sickle cell disease is a prothrombotic disorder. There's increased incidence of left-sided heart dysfunction owing to diastolic cardiomyopathy, alterations in sort of vasoactive molecules as a result of the sickling process and hemolysis that can affect the architecture of these blood vessels here. Different studies have indicated that the prevalence of pulmonary hypertension in sickle cell disease is anywhere from 6 to 11%, and this diagnosis does significantly impact on morbidity and mortality. And as was alluded to in an earlier session by Dr. Cantor this morning, the guidelines do vary in terms of whether or not we should be using echocardiogram to screen for the presence of pulmonary hypertension or relying on detailed clinical assessment. The symptoms of pulmonary hypertension can be quite vague. So there was actually a questionnaire that was developed by the American Thoracic Society trying to sort of help to tease out whether or not the person in front of you may actually have some early findings of pulmonary hypertension. And I won't go through these questions in detail, but a lot of them really get at sort of the onset of shortness of breath or dyspnea with varying levels of activity or even at rest alongside peripheral edema, so swelling either within the ankles, legs, or sometimes the abdomen. Right-sided heart catheterization remains the gold standard for diagnosis of pulmonary hypertension. So a catheter is essentially thread up into the heart, and through various calculations that are beyond my brain, they're able to sort of dictate what the pressures in the pulmonary arteries actually are. Obviously, this is a more invasive test, and it is required for individuals where there's suspicion for pulmonary hypertension, but there are less invasive tests that can be used to start, and that can again be through echocardiogram, looking at different measures and metrics on the right side of the heart, of which the tricuspid regurgitant jet velocity tends to be most specific for pulmonary hypertension, and then even tests like blood work, like an NT-proBNP, which can indicate some general strain on the heart, alongside other tests that are used for pulmonary hypertension, not necessarily specific to sickle cell disease, but even things like a 6-minute walk test. The treatment of pulmonary hypertension in sickle cell disease is, I'm getting a flag here, I think, is multifactorial, but basically we can look at sickle cell disease-specific therapies along with pH-specific therapies. So hydroxyurea, again, comes out here through many different ways. It's able to sort of prevent and treat pulmonary hypertension. This may be done in conjunction with transfusion therapy, depending on the severity. Also important is the treatment of comorbidities, which are also known to contribute to pulmonary hypertension, like obstructive lung disease, left heart disease, respiratory diseases like asthma, and then there are pH-specific therapies as well. The thing I'll say about this is that these specific therapies, so things like endothelin receptor agonists, we do need to be quite cautious in their use because some studies have shown that there's actually an increase in incidence of vaso-occlusive pain episodes when these agents are used. So really this needs to be done on an individual, carefully selected basis here. I won't go into the study in detail, but there was a trial that was published in the Lancet Hematology in May of last year looking at an entity called riociguat, which is used for certain types of pulmonary hypertension, pulmonary arterial hypertension, which is group 1 as per the WHO, and also in chronic thromboembolic pulmonary hypertension. And there was some promising data. So potentially there will be some evolving therapies. But really at the crux of pulmonary hypertension management is sickle cell disease is making sure that this is being done in a center with pulmonary hypertension center expertise. So it does require careful collaboration. So to summarize, in terms of the acute chest syndrome, how to spot it, essentially the very basic definition is that you have a new infiltrate on chest x-ray, either together with a fever and or some nuanced respiratory symptoms. There are multiple different causes and the clinical course can be quite variable, ranging from mild to quite severe, warranting ventilatory support with associated multi-organ failure. In terms of how we're treating it, that's supportive care, aggressive pain management, broad spectrum antibiotics, transfusion therapy, those all remain quite key. Pulmonary hypertension, how do we spot it? Typically that's going to be an increase in dyspnea or shortness of breath, either at rest or with minimal physical activity, along with some pulmonary edema. While right heart catheterization remains the gold standard, a lot of times in terms of your detailed clinical assessment, you're going to be sort of screening for it through questionnaires and following up with an echocardiogram if you do have those concerns that the person might have it. And treatment is multi-pronged. Again, you're going to be addressing those comorbidities that are at an increased prevalence in individuals with sickle cell disease that can contribute to pulmonary hypertension. So again, lung diseases, restrictive defects, asthma, obstructive sleep apnea, left heart disease, those can all contribute to the development of pulmonary hypertension over time. So that requires careful management together with sickle cell disease specific therapy like Hydrea, sometimes in conjunction or actually just using transfusion therapy and ensuring that you are working with a pulmonary hypertension center of excellence. So I thank you for your time and attention, and I'll pass off to Dr. Forte, who's going to take over from here.
Perfect. We're going to probably save questions for the end, just in conscious of time.
Thank you. Okay, thank you for a beautiful talk. Okay, so I'll give you a bit of background about this dramatic image here. We all heard about unfortunate events about patients with sickle cell disease not receiving the best care for acute chest syndrome. Some of them, unfortunately, passed away, and we're all committed for this to never happen again. So one of the things is education, and I found that I often give presentations, and then I realize I need to have more impact on my emergency docs, emergency colleagues, on the residents. We all have a very short attention span. We're all exhausted. So I'm trying something more dramatic. Maybe it's too dramatic. You'll tell me at the end. And just let's give it a try. So stop the fire before it spreads. Here it goes. Sorry. Okay. So acute chest syndrome is the second most common acute complication of sickle cell disease, and it's most common in children. And so amongst 100 children, you could have 30 children in a year that can have acute chest syndrome. And luckily, it's quite rare that children die of acute chest syndrome. And in adults, it's a bit less common, but it can be more dangerous. Not saying that in children it can't be dangerous, but there's a certain type of acute chest syndrome that's more common in adults, and that's the rapidly progressive acute chest syndrome that's associated with 6% mortality. Now, I have a question for you. Do patients with milder SC disease not get acute chest syndrome? So can you base it on the genotype to diagnose acute chest syndrome or not? No. But that's a good one, because some patients told me, I was told I cannot have acute chest syndrome, I'm SC. I don't even have anemia. So this is some of the stuff we hear. So this is false. It is true that the incidence is lower in SC disease, but they can still get it. And this is a nice series of patients from Toronto by Dr. Nasons and Dr. Kuo and Dr. Ward that showed that you can have there were 8% of patients with SC that experienced at least one acute chest syndrome, and in the French cohort, it was up to 20%. Okay, next slide. So, what is rapidly progressive acute chest syndrome? So, we can see that in about 2% of children and 20% of adults with acute chest syndrome. So this is when, within the first 24 hours, actually, there's a rapid deterioration and people go into respiratory distress and they need ventilatory support. So you see, you have to act fast because it can go really fast. And you can have very serious complications because then less oxygen is transported to the different organs and there's lots of inflammation and fat emboli that go on. So there can be acute injury to the brain with stroke, seizures, confusion, and other organs as well, so kidney failure or liver failure, for example. And this can leave long-term scars, such as pulmonary fibrosis or pulmonary hypertension, like we saw in the previous case study. And of course, patients could have psychological sequelae from that and the trauma of having to go through like a life-threatening event. So acute chest syndrome, if you remember the definition, it's very simple, actually, and it has to be simple and very pragmatic so that everyone can spot it. It's so simple that often medical students, they tell me it can't just be that. No, it is that. So there's no way you can forget it, you know? Everyone should know it. So it's fever, cough, chest pain combined with a pulmonary infiltrate. So when you look at the chest X-ray here on the right side, which is actually the left lung, the lung is black because there's air, it's filled with air. But on the other side, you see the lung turning white, similarly to the liver, and that's because it's filling up with fluids, with pus, there's inflammation, and the blood is not flowing. So that's what acute chest syndrome looks like. And it's frustrating. It looks the same as a pneumonia. So is it pneumonia? Is it acute chest syndrome? It's both, like probably. So it is acute chest syndrome, and it's something that can be the presenting symptom when the patient comes to the emergency room. But it can also develop while the patient is there for another reason. So you have to recognize it wherever the patient is in the hospital. Okay. So another question for you, a statement, true or false? For most patients, acute chest syndrome is caused by an infection. False? True? Now we're testing who listened to your talk, to all the sections. Okay, so what can we say? So this is the big study we were discussing previously. So in most cases, actually, close to 50%, the cause is unknown. Okay? But there are infections, obviously, viral infection, bacterial infection, there's infarction, there's pulmonary, there's fat embolism, so many things. And COVID also is a new one that can be added to the list of causes. Now, what sparks acute chest syndrome? Why is this happening? The patients ask me, why did this happen? And most of the time, like half the time, we don't know. And sometimes it can be several triggers at the same time. But this should not change how we manage the acute chest syndrome in the emergency room or in the ward. The initial steps should always be the same. So in children, more commonly, it can be an infection or asthma that triggers the acute chest syndrome. And in adults, we see more of the pulmonary infarction and fat embolism. But the important thing is this starts a cycle of vasoocclusion, and it will spread. It first can start with a small section of the lung where the oxygen is not transferring to the blood because there's fluid filling up in the lungs. But then there's even more sickling going on because of the low oxygen, the inflammation, etc. And that's when you need to act fast. So early warning signs are the symptoms that we discussed previously. So cough, fever, chest pain, fast breathing, and low oxygen. Now, I have a question for you. Why do you think that we still miss acute chest syndromes initially? And I really want to hear from you guys in the room, if you have any experiences or thoughts why this gets missed. Yes?
Sometimes it's just might be a cough.
Yeah? Yeah?
Or you think I just have a cold.
Yeah, so the patient might think this is just like any other cold I had. It's just, yeah.
Or like me with asthma.
Oh, asthma, yeah. Yeah, so maybe the healthcare providers don't know to recognize it. Oh, yeah, that's what happens. Huh? The patient has so much pain. Actually, there's one of my patients had pain in the shoulders. It was so bad. I did X-rays. I sent the patient to magnetic resonance imaging, but it was actually the lung filling up with pus and just getting really sick and irradiating to the shoulder. So that can be a pitfall when you focus just on the pain. So the other thing is sometimes it could be the first time the patient presents with an acute complication of sickle cell disease. So some patients don't know their status, and it could be the inaugural presentation. Providers may lack the knowledge. Onset can be insidious, so you might miss the early signs. Patient may be admitted for something else, like a surgery and anesthesia. The surgeon, no one registered that the patient had sickle cell disease, and then suddenly there's respiratory distress. It can deteriorate rapidly, and some of the pitfalls as well is when you focus on the pain and less on the breathing. The other thing is sometimes patients get very restless and agitated, and then there's this tension building with the care team, and then you start losing the focus. And the other thing that can happen is suddenly the patient is not asking for any medications anymore. So you think, oh, he's finally getting relief, but actually that's when the bad things start to happen because the patient is hypoventilating, and that's when the acute chest syndrome is starting. And actually, the patient is not asking for anything because he can't anymore. He's already too somnolent. Now, whoops, this is not working. Would you mind moving my slide, please? Okay. Yeah, now it worked. Okay, so the best way to manage acute chest syndrome is when you have a predetermined order set and you have a predetermined path in a hospital, and that changes outcomes, and there are publications about that. So you start the treatment usually in the emergency room, and then the intensive care, hematology, internal medicine move in, and if you act fast, you can really have better outcomes. So what does it mean? So we talked about the oxygen. So that's an important first step. Antibiotics. So usually we don't wait to know if it was really pneumonia or what bacteria it was. All get treated with a combination that addresses community-acquired pneumonia. So it's usually ceftriaxone, azithromycin. But if the patient has allergies or there are specific resistances of bacteria in your area, so this may vary. The other thing is pain relief is really important because if the patient is in too much pain, Then there's splinting, there's even less breathing and less oxygen reaching the lungs. So pain relief is part of it, but you don't want to over-medicate, and especially combinations with IV gravel, IV Benadryl. We try to avoid to not make the patient even more somnolent. Then there's the breathing exercises that we continue through the acute chest syndrome if the patient can. And that also includes making the patient walk as soon as possible. So sometimes we bring in physiotherapy to help the patient ambulant walk and do deep breathing. Now, close surveillance is important throughout the episode, and transfusions. So transfusions are tricky, and it's a complex decision. It is a complex decision, and it's one that we make as a team. So what I really want to instill into my emergency medicine docs and my colleagues in internal medicine, like, please call us right away when you have an acute chest syndrome. Don't wait for it to get really bad, you know. We need to call the blood bank. Maybe the patient has rare blood, and when you need to get it from somewhere else in Canada, maybe the patient will need apheresis, you know, exchange transfusion. Then we have to get the nurse come in the middle of the night. The patient will need access, venous access. So there's a lot of things to plan. Don't wait for it to get bad. The other thing is, for some mild cases, sometimes we can avoid transfusions, and we are happy when we can. Often in pediatrics, when it's a mild acute chest syndrome, it evolves really well. We can sometimes avoid transfusions. So it's something that needs to be discussed with the expert. And what are the goals of transfusions? Well, it's simple. You want to increase oxygen delivery, so you stop the sickling from happening. You want to reduce the amount of red blood cells that have sickled hemoglobin, but you also want to avoid to get the sluggish blood and the hyperviscosity, so you don't want to transfuse too much. So that's where it can get tricky sometimes. So maybe if the patient has very severe anemia, you can get away with just giving 1, 2, 3 transfusions, and that will be enough to reach 100 grams per liter of hemoglobin and dilute the hemoglobin S. Now, if you have someone who has a bit higher hemoglobin, do we need to go straight to exchange transfusion? Maybe if it's a mild, moderate case, we'll start with 1 unit of blood. And I've seen patients actually turn the corner with just 1 unit of blood. So maybe this patient will not need 12 units of blood. So that can be an option. The other thing is sometimes you are waiting to transfer your patient to another center that has exchange transfusion. So you can still, you can start doing that, so you are already helping your patient and not delaying further treatment. Or maybe it's a rare blood, so you start with 1 unit while waiting for other units to arrive. And then for the more severe cases, it's exchange transfusion that will be needed to really fix the acute chest syndrome. Now, we talked about the acute management. You heard about the preventive strategies earlier. I think we can always, if such an event happened to a patient, it's always an opportunity to go through all these preventive measures again, and that's what we do in the hematology clinic. So vaccines, asthma control, avoid smoking. Children need their penicillin prophylaxis. And then other things is when the pain crisis starts at home, we need to treat it fast. So we have to be really good about ambulatory pain management of acute pain. The other thing is before surgery, discuss with your care team about the surgery that's coming up, because there's some planning we can do, and for high-risk surgeries, the hematologist will probably recommend a transfusion. And pregnancy is another time of extra caution, it's even postpartum, so at the slightest sign of pulmonary, of acute chest syndrome, there should be a care. Now, in terms of research, this is exciting actually, and then I'll finish on my key messages. There are different groups that are trying to find smarter ways for prevention. One strategy I really liked, and it was highly efficient during COVID, it was actually patients in Créteil in France showing up in the emergency room with acute pain episode. And there were not enough beds for everyone, so there had to be some kind of triage. So they said, okay, let's use our prediction score for acute chest syndrome. If you are low risk, you are going home, you're getting telemedicine, a nurse will come once a day, and we will manage the pain at home. If you have high risk, you get on the ward. And it was highly effective, actually, and now this work has been reproduced in different countries in Africa, and I think that's a smart way to do it, that you identify the high-risk patients right away. The other thing is, could we identify something in the blood, a biomarker, before the acute chest syndrome happens? And that's an active field of research. And finally, anticoagulation, like we heard about, there was a breakthrough, like a very important publication that came out from the French group, and that will change practice. So there will be some patients where we will prescribe anticoagulation to see if the acute chest syndrome can resolve faster, and also if can we avoid in the long-term complications such as acute chest, pulmonary hypertension. So that's another field of research. So the take-home messages with acute chest syndrome, you have to identify it rapidly, you have to act immediately. You need a multimodal approach, you need a highly effective team to manage it, and there are some preventions that can avoid it. The message I want to leave here is that we can optimize the care delivery for acute chest syndrome through advocacy, education, quality improvement, just showing the metrics to our e-docs, that has a big impact. And the other thing is we need a lot of research to improve the care, so actually we can completely avoid the acute chest syndromes. That would be the goal. So thank you for your attention.
Thank you. Truly fascinating topics. I'm really enjoying the session. But not to close us off in the right way, we have Dr. Donnell Ivey, who's going to share a bit more of a lived experience perspective on acute chest syndrome and the elements that come along with that. So over to you, Dr. Ivey.
Yes, so I'm going to talk more about my personal experience with acute chest syndrome. I will talk some about the medical aspect, but I love actually sharing this story because it was the actual turning point in my life. So I was fortunate enough to be the first person in my family to go to college. I attended North Carolina State University in Raleigh, North Carolina. And the way I managed my sickle cell pain and condition when I first got to NC State was to go to the school infirmary. So NC State had an infirmary, I'll go there, and fortunately there were doctors that were willing to work with me. They weren't sickle cell experts, but when I came in a painful crisis, they'll start an IV fluid, give me some pain medicines, and hopefully it would resolve. I can go back to class, but there were times when they recognized that, okay, it's beyond their expertise and understanding, so they would transfer me to the local hospital in Raleigh, North Carolina. Now, this continued. I would have maybe like 4 or 5 painful crises events that would cause me to go to the infirmary. Some of them would result in me having to go to the hospital in Raleigh. It was during my 3rd year that I woke up one night, or one I would say late evening, and I had left the window open, and it was cold in the room, and I recognized immediately. So individuals that have sickle cell disease, I had become so attuned, I knew when a crisis was coming. Even before it fully happened, I knew, okay, hey, I'm in crisis. So I called for help, and I had to go to the hospital in Raleigh. I went there because I was having leg and hip pain, right? I was in the hospital, got to the hospital. They did take me back into the emergency room fairly quickly that day. I think it was like an hour and a half, 2 hours. Well, yes, and so I can tell you stories about how, growing up, it was, I think it's gotten better, but, I think that day was like an hour and a half, 2 hours, which I considered fairly quickly. Because I've been in hospital visits where it was like 8 hours before you go back. You get 1 dose of IV opioid, and then you have to wait 4 hours before you can get the next dose. But that's another story. But at any rate, I wanted to bring attention to the fact that I went because I was having leg and hip pain. Now, they were treating me, and on day 2 or day 3, I can't remember exactly, the nurses started making a big fuss. And I was just laying there. They had put me on oxygen. I had an oxygen mask on. I was wondering what was going on. And then the next thing I knew, they were wheeling me back to somewhere. The doctor took off the oxygen mask, and it felt like they had sucked the oxygen out of the room. Like, I can't breathe at all. And I wake up, I have a Swan-Ganz catheter in my neck, and I'm intubated, And they are coming in often, checking on me, seeing what's going on. I remember my mother. So my mother had schizophrenia, and she lived about an hour and a half away from Raleigh. And so we grew up very, very poor. So for her to get to Raleigh, I knew, okay, hey, well, why is my mom here? Because I'd never seen her in Raleigh before. And I see her and my sister and my brother. And then shortly after they visited, then they're saying, okay, well, we're going to transfer you to UNC Chapel Hill because you're so sick, we don't think you're going to make it if you stay here. And so they transferred me to UNC Chapel Hill, which was the best experience because I met Dr. Gene Oringer, a hematologist that was specializing in sickle cell disease. Now, I stayed in the ICU at UNC Chapel Hill for about 20 days, intubated, and receiving blood transfusions. They did exchange transfusions. I remember it was my first ever exchange transfusion. They had to put one needle in each arm. And I'd never seen that before. But it was after that they prescribed hydroxyurea to me, which actually was a game changer for my life because I went from the 4 to 5 crises a year, just had an acute chest syndrome episode, to none. But before I started hydroxyurea, I was like, oh, I don't know. The doctor would come in and, hey, you need to, really consider hydroxyurea. And I was a little hesitant until he told me one thing. He said, Donnell, you just had an episode of acute chest syndrome. And sure, we can start hydroxyurea and, hey, it could give you cancer 20 years from now, or, hey, you might have this side effect 30 years from now. But the likelihood of having another episode of acute chest syndrome is very high after you've had one. So you could leave here, not start hydroxyurea, have another episode of acute chest syndrome in 6 months, and die from that. And that put things in perspective. Sickle cell disease is a very severe disease. We have to treat it, and we have to figure out what are those strategies to help us identify who's at risk and get them the therapies that they need so that they can stay healthy. Now, I talk about that experience, and I just want to say that mine started out as hip pain. And they did do what's called a bronchial lavage, so that's where they go in and they're trying to figure out, what is it that's causing it? And what they found in me was the fat-laden macrophages, right? I had the hip pain that somehow released fat into the bloodstream because I had, necrosis of the bone tissue that released fat, and then the fat had gone to my lungs, and that was what's causing the problems. And there are situations where that can continue to happen, and you can have what's called fatty emboli syndrome, where fat is released, and that fat can travel to the lungs and get stuck. It can travel to the brain and get stuck. And there are quite a few individuals with sickle cell that may go into multi-organ failure if it's not identified and treated. So we have to help doctors to understand, but we also have to take the steps ourselves as patients to say, how do I help explain what's happening to me so that the doctors know that I'm just not here for a pain crisis. And I'm one of those sickle cell patients, I do apologize, that I don't like to focus on pain because pain is a symptom. And it's a symptom of tissue damage that's happening in your body. And that tissue damage is ultimately what's going to lead to death. It wasn't the pain in my hips that was going to kill me. It was the acute chest syndrome that was developing. It's not the pain in my side sometimes that's going to kill me. It's going to be the renal failure. It's not that severe headache that's going to kill me, it's that stroke that's happening. So we have to make sure that, yes, we want our pain treated, but we also have to make sure that we're treating the disease as we do this. The second time I had acute chest syndrome, and I have to admit, it was my fault. I was in medical school. Things are challenging and tough. I let my hydroxyurea slip some. and it was 2 weeks or about 3 weeks before I was to take the USMLE, step 1 of the USMLE. And I was having pain for about, a couple of days, and I could say, I have whenever I take a deep breath, it hurts right back here, and I could almost put my finger on it. And so eventually I go to the emergency room at the medical school, and I don't know, I was fortunate because I was a medical student. I was talking to the doctor, and I said, I'm having pain when I take deep breaths, and when I lay down a certain way, it hurts, and it hurts just right here. And so first she did an x-ray, and the x-ray didn't show anything. And so then I'm laying there, and I'm saying, yeah, I'm having this. She was like, well, we don't know what to do. So then she said, well, let's do a spiral CT. Now, I'm laying there. She had done it's a CT exam, and I'm laying in the bed, and she comes in frantic, and she says, we got to get you admitted right away. It looks like your lungs are full of blood clots, right? So they take me in. Here I am thinking about my USMLE exam. I'm in the hospital for about 2 weeks, and they do a bronchial lavage again and fat-laden macrophages. So each of the time I've had it, it's been due to the fatty embolism. But I want to bring your attention that sometimes we have to be persistent, that, hey, there's something going on, that there's something that needs to be taken care of. So each time, if I hadn't been listened to, or if I would have had doctors that really didn't pay attention to what they were doing, I wouldn't be here talking to you today. I could have died at that hospital in Raleigh. Particularly if I didn't have doctors that had the foresight to say, I don't know what to do here, I'm going to call for help. And they reached out to other doctors. Or I could have died in medical school when I was talking to the emergency room doctor, and she said, oh, the chest x-ray showed that everything's okay. But actually an additional test showed that, no, everything's not okay. So we have to figure out how to become more in tune with our bodies, how to talk to doctors, and then also how to help those doctors understand that what are those best treatments. Now, I was fortunate. I started hydroxyurea. I know hydroxyurea doesn't help work for everybody, but I would strongly encourage individuals, try hydroxyurea. Sure, the pain is bad, but look for other strategies to treat your sickle cell disease. And so I'll stop with that and allow for more questions.
Oh, my God. Folks, each of these sessions, I don't know what to expect, but they get better and better each time. I appreciate just the layering of all three of your presentations, and it really resonated. Now we have a few minutes for questions. I want to open the floor and see if there's any questions from the audience. Go ahead.
Hi, good afternoon once again. I want to ask the question to the last speaker, who happens to be a doctor and also the person who suffers from sickle cell disease. For the last 2 days, I've been blown away. I'll be louder, don't worry.
Oh, no.
Yes, I've been blown away with all the information that you pass on to us. First of all, you are conscious and you are intubated, so you can see people going around you doing things, and you cannot even talk.
Yes.
And I cannot imagine that. Because even when I'm on break and people are talking, I don't want to talk. Anyway, so I cannot imagine what people with this disease go through. So thank you for sharing your experience. And I don't know what to say. But,
I will say, with that experience, the worst part of that acute chest syndrome it was when I got out of the hospital, and then I realized why my mother had come up to visit. So she said that they had been calling her every hour giving her an update about me. And that they called her at one point and said, you need to come see your son because we don't think he's going to make it to the next hour. And thinking about that really, I mean, it devastated me. What she must have been going through, what was going through in her head, that, hey, I'm traveling to Raleigh to see my son for the very last time. And so, you know, we have to think about, yeah, it's tough, but sickle cell affects more than just the individual living with sickle cell disease. It affects the community that they have around them. But yeah, it's been tough, but yeah, we have to figure out how do we help the community become more resilient.
Any other questions from the audience? I have a question. It's actually for all three of you. I mean, what's most disheartening about this is just how do you discern the significance of the presentation when it just seems like it could be anything? So from a medical education and a quality improvement standpoint, if you could each provide me with your own specific feedback or insight you'd share with a young professional about how to be, you know, equipped to respond to this the right way.
Thanks, Delaney. I think that's a great question, and I anticipate Dr. Forte likely has a more intelligent answer than I do. I think from my perspective, it's the awareness piece, like Karen had mentioned there. I think you don't know what you don't know. So when you're, you know, when hematology is all you do, you know about these things. But for providers who work in different settings and they're not necessarily managing people with sickle cell disease on a day-to-day, again, it's probably not something that's at the forefront of the brain when somebody's coming in with pain. And it's knowing that it may not be there on the day that the person's presenting to the hospital, but it certainly can develop when they're admitted. So I think it's just making others aware of what the condition is and not to forget about it on day 2 or day 3 of admission of maybe at what seems like an uncomplicated pain episode.
Fantastic.
Thank you. Yes, I agree. Actually, it's the level of vigilance and also to be humble, because there was some patients I thought, they'll probably likely go home in 2 days, and it's actually when the acute chest syndrome happened. I mean, there are some list of signs that, if someone wants a list, there are lists out there and the students can learn about them. Like when the platelets are lowering in the blood counts, or if white blood cells are very high, or if the respiratory rate goes up. So there are these lists, but in the end, what I tell, you just have to be a good doctor, and being a good doctor means like sometimes you just have to go see the patient maybe 2 or 3 times that day. There's sometimes, I take the students with me and it's like, how do you feel right now looking at this 18-year-old person? Do you feel well? And they're like, oh no, I'm really worried. Like there's something. It's almost like you feel it. It's like the way they're breathing, the stress. They're not doing well. I'm like, okay, well this person, it can really go bad, and we have to act fast. So there's something really. It's not normal when you're 18 to be out of breath like that. So it has to trigger some kind of hypervigilance. And sometimes it means also trying to convince ICU doctors to admit patients for observation, but that's very, very difficult because of limited beds. So we try different tricks around it. Sometimes it means staying on a monitor longer in the emergency room, but it's difficult because there's no system in the hospital really to monitor our patients like they should. So it's more of a system level as well, because we can be worried, but we cannot be 24 hours there besides our patients.
No.
So we need the system to improve, I think. Would you like to add?
And I would just say I'm going to take a different approach. So one of the reasons I left practicing medicine was because I think, as it was said, we need a systems approach. And I'm a strong believer that system has to include patients at the center. We have to help patients to understand that sickle cell disease is beyond the pain crises.
Right.
It's not the pain crises that's going to kill you. It's the other things like acute chest syndrome. It's the other things like a stroke. Those are the things that will kill you. And so helping patients to understand what all of the risk factors are in sickle cell disease, even beyond the pain crisis. We have to, educate our patients to step beyond the pain crisis. Sure, we want that treated, but we have to also help them to understand that it's acute chest syndrome, it's pulmonary hypertension, it's stroke, it's renal failure, it's loss of eyesight. Those are going to be the things that are really going to cause problems, and I think helping patients to understand it. So I'm a big believer in the use of community health workers. I'm a big believer in educating patients so that they become a partner in making some of those decisions.
From the presentation, I'm understanding necrosis, as you just said, can cause multi-organ embolism. So shouldn't doctors be more vigilant in testing when patients present with different organ issues? And what do you ask?
Yes, and that's a tricky question because there's so many things. I was just on an echo session that they were having in the U.S., and they had a patient that had become very severe and very sick with multi-organ failure. And the ER doctors thought it was HLA, and I'm going to mess up the name, hemophagus, yes. And so that's another condition that can look like fatty emboli syndrome. And so, I remember as a child, when we look at the progression of sickle cell disease, and I have to admit, I don't know what the number one cause of death is, but I know infection used to be way up there. And we found a way to treat that with penicillin prophylaxis. So that was the first thing that helped individuals live longer. And then we found, okay, well, hey, they're not dying of infection, they're getting strokes though. So then we started doing TCDs, and then hydroxyurea. And so we have to look at, there are a lot of different factors that can lead to the demise of individuals with sickle cell disease. Infection is still huge, strokes, and as you were saying, multi-organ failure that can come from fatty emboli syndrome, that can come from other complications. So we have to make sure that the doctors don't focus so much on the pain that they fail to look for some of these other things that can be life-threatening.
Yeah, well, I think the fatty embolism are probably more often a cause that we know. But the question is, how does it change the treatment? So actually, in the paper you presented, they went and did bronchoscopies to a lot of patients, and it was very seldom did it change the course of the treatment. So it's very invasive. And so knowing that it was fat emboli, I don't know if that would make a difference in most cases. The only situation I can imagine where it would change the treatment is in the most severe cases of acute chest syndrome with multi-organ failure that continue to deteriorate after red blood cell exchange. There's a situation where you can do plasma exchange. So it's almost like exchanging the whole blood, so the red blood cells and the plasma. And there was a publication on that, and patients, it seemed to help them improve. But often you can make the diagnosis without finding the fatty macrophages. Actually, pathology doesn't look at them for us, unfortunately. Yeah. They stopped doing that. I don't know, at your center, do you look for the macrophages? Yeah.
Last chance, any final questions? Okay, with that, if you can join me in a round of applause for our panelists.